Hey guys, tonight we're stepping into one of the most unsettling medical rabbit holes in modern history. A little white pill that was supposed to give you your life back, and instead quietly tried to take it. Not dramatically, not all at once, but slowly, in the way that really good marketing does, a whisper at a time, a prescription at a time, until one day you're staring at a pill bottle wondering how you got here. We're talking about Lyrica, generically known as pregabalin, nicknamed by some patients the Coffin tablet, and if that doesn't already have you curious, I don't know what will. Before we go any further, take a second to like this video and subscribe, but only if you actually enjoy what I do here. Leave a comment telling me where you're listening from and what time it is. It's always 2 in the morning somewhere, and I find that oddly comforting. The channel is also now live on Spotify. Links in the description, so if you ever want to drift off without a screen, we've got you covered there too. Now, dim the lights. Put a fan on if you got one. Pull your blanket up, get your pillow in the exact right spot, you know the one, and let yourself get comfortable. You've earned this. Let's pause for a second and just sit with a few questions. Have you ever taken a pill that was supposed to fix one thing and somehow made 12 other things worse? Have you ever trusted a drug company the way you trusted a person, and then felt that specific, hollow kind of betrayal when you realized they knew the whole time? Did the FDA ever look at a drug that causes memory loss, swelling, suicidal thoughts and addiction, and think, yes, this seems fine, let's approve it for anxiety too? How does a medication originally developed to treat epilepsy end up in the hands of people with bad backs, frayed nerves, and fibromyalgia they can't pronounce? And how does a drug that was never approved for withdrawal symptoms manage to produce some of the most brutal withdrawal symptoms in modern pharmacology? Congratulations, you've just woken up in the late 1990s. A pharmaceutical company called Parke-Davis has a molecule on its hands, and they're extremely excited about it. You don't know yet what's coming. Nobody does. But something is already in motion, quiet, clinical, and dressed in a white coat. In the early 1970s, a chemist named Lyrica at Northwestern University was doing something that sounds almost poetically misguided. He was trying to synthesize a version of GABA, gamma-aminobutyric acid, that could cross the blood-brain barrier. GABA is the brain's primary inhibitory neurotransmitter. Think of it as the neurological equivalent of that one friend at a party who puts both hands up and says, "Hey, hey, hey, everyone calm down." The brain is throwing a full panic, neurons firing in every direction like toddlers on a sugar high, and GABA is the one walking around quietly turning the music down. The idea was elegant. If you could synthesize something that mimicked GABA and actually made it past the blood-brain barrier, that very selective bouncer standing between your bloodstream and your brain, you might be able to calm an overexcited nervous system from the inside. Seizures, nerve pain, anxiety, all the ways a nervous system can stop being your friend and start being your problem. It was, in theory, a beautiful solution. What Yoneda and his team eventually produced was a compound called gabapentin. It had a structure that looked like GABA in the way that a drawing of a house looks like a house. Recognizable, related, but not quite the real thing. And here is where it gets interesting, because gabapentin did not actually work like GABA once it was inside the brain. It did not bind to GABA receptors the way everyone expected it to. It did something else entirely, something that took scientists years to fully map out. It attached itself to a specific subunit of voltage-gated calcium channels, essentially turning down the volume on neurons that were firing too fast and too loud. Not a GABA mimic after all. Something new. Something that, at the time, nobody had a clean category for. It is the scientific equivalent of inventing something that was supposed to be a spoon and accidentally creating a fork. Still useful. Still impressive. Just not what anyone was aiming for. Parke-Davis, a pharmaceutical company with its eye on neurological treatments, licensed the compound and began developing it through the 1980s. The FDA approved gabapentin in 1993 under the brand name Neurontin for use as an adjunctive treatment for epilepsy. Adjunctive meaning alongside other drugs, not replacing them. A supporting actor, not the lead. That framing mattered because it told you something about how cautiously even the most optimistic people involved were willing to go at first. This was not a drug being handed to every person with a headache. It was a supplementary tool for a specific, serious, difficult-to-manage condition. But gabapentin worked. Not always dramatically, not always predictably, and certainly not for everyone. But for some patients with certain kinds of nerve pain, it offered something they had not had before: relief. And for some epilepsy patients whose seizures had been difficult to control, it provided an additional layer of management. The drug was real. The benefit was real. And somewhere in the middle of all that, a thought began forming, quiet at first. The way most consequential thoughts are, that the mechanism behind gabapentin might be worth refining. Tighter, cleaner, more potent, more predictable. More of everything that made gabapentin useful, with less of what made it inconsistent. That refinement would eventually become pregabalin, and pregabalin would eventually become Lyrica. And Lyrica would eventually become one of the best-selling drugs in the world, with annual revenues that would peak at around $5 billion, and a shadow behind it that kept growing the more people looked directly at it. The molecule that started everything was modest, cautious, and genuinely useful. A chemist trying to calm the brain and accidentally finding a new way to do it. That part of the story is almost charming. What happened next was considerably less so, and we're going to walk through all of it, slowly, because the details are where the story lives. By the mid-1990s, Park Davis was quietly working on something they considered a significant upgrade to gabapentin. They called the new compound pregabalin, structurally similar to its predecessor, but with a more predictable absorption rate, a stronger binding affinity to those calcium channel subunits, and a cleaner pharmacological profile overall. On paper, it was better, more efficient, more controllable. The kind of molecule that makes pharmaceutical scientists feel the way a chef feels when a sauce finally reduces to exactly the right consistency after 40 minutes of patient stirring. There it is. That is the one. Park Davis began running clinical trials. The early data was promising, particularly for neuropathic pain and epilepsy. The drug behaved more reliably than its predecessor. Blood levels were more predictable. The dose-response relationship was cleaner. Everything pointed toward a compound that could carve out a meaningful place in the treatment of conditions that had, for a long time, been genuinely difficult to manage. For the researchers working on it, pregabalin represented something worth being excited about, and in the world of pharmaceutical development, where most compounds fail before they ever reach a patient, that kind of clean early data is not nothing. It is in fact everything. But then something happened that reshaped the entire trajectory of the drug. In 2000, Pfizer, one of the largest pharmaceutical companies on Earth, a corporation whose marketing infrastructure operated at a scale that most governments would find humbling, acquired Warner Lambert, which had itself absorbed Park Davis some years earlier. And just like that, pregabalin went from being a mid-sized company's promising compound to sitting in the portfolio of an organization with the resources, the reach, and the institutional appetite to do something very large with it. This is not a small distinction. A promising drug in the hands of a mid-sized company is one thing. That same drug in the hands of Pfizer is something else. Not because the molecule changes. The molecule does not care who owns the patent. But the machinery that surrounds it, the sales force, the marketing budget, the relationships with physicians and hospital systems and insurers, the capacity to run multiple large clinical trials simultaneously, and to publish results in major journals and to fund the medical education events where prescribers learn what they should be recommending. All of that changes enormously. Pfizer had already been through the Neurontin saga by this point, and we will get into that in detail shortly, so they understood the terrain. They knew what a nerve pain drug could do commercially if it was positioned correctly. They'd seen how a molecule with a specific approved use could become something much broader in practice. And they had a plan for pregabalin that was, from the beginning, considerably more ambitious than anything Parke-Davis had imagined. In 2004, the FDA approved pregabalin under the brand name Lyrica for the treatment of diabetic neuropathy and postherpetic neuralgia, nerve pain caused by shingles. The following year, it was approved for fibromyalgia. In 2008, generalized anxiety disorder was added in Europe, though that indication took longer to gain traction in the United States. Each approval opened a new market. Each market represented millions of patients. Each patient represented a prescription, and each prescription represented revenue on a scale that most industries can barely imagine. What made Lyrica commercially different from Neurontin, at least in Pfizer's eyes, was that they owned the intellectual property cleanly and completely. They had strong patent protection. They could control pricing in a way that Parke-Davis never could have, and they could market it directly, both to physicians through their sales force and, in the United States, directly to consumers through television advertisements, featuring soft-focus imagery of women walking on beaches and smiling warmly at their grandchildren, accompanied by a narrator reading a list of side effects at a pace so brisk you would need a court reporter and a stopwatch to fully capture it. Pfizer positioned Lyrica not as a drug of last resort for complicated neuropathic conditions requiring specialist management, but as an accessible, manageable solution for the chronic pain that millions of ordinary people were quietly living with and not getting adequate treatment for. That framing was not dishonest. The undertreated pain was real. The drug was a real treatment. But the gap between genuine treatment and appropriate treatment for every case, for every patient, for every duration, that gap would eventually become the story. And it would take years and a lot of suffering for people to see it clearly. Before Lyrica had its moment in the sun, its chemical ancestor was already starring in one of the most thoroughly documented pharmaceutical fraud cases in United States history. And if you want to understand how Lyrica ended up prescribed to what sometimes felt like half the Western world, you first need to understand what Parke-Davis did with Neurontin, because Lyrica was, in many ways, built on the same strategy, just with better legal insulation, better paperwork, and the hard-won knowledge of exactly where the previous version had gotten caught. Neurontin was approved for epilepsy. That was it. That was the lane. A specific drug for a specific condition cleared by a regulatory agency with specific data from specific trials. Simple, clean, legal, and deeply insufficient from a commercial perspective for a company that had spent years and enormous resources developing the compound and was now looking at a market of epilepsy patients and thinking, this cannot be all of it. By the late 1990s, Parke-Davis had identified something intoxicating. Doctors were legally free to prescribe medications off-label, meaning for conditions the FDA had not formally approved the drug for. The company itself could not legally promote off-label uses. That was a clear line in federal law. But sales representatives had conversations with physicians that were not technically promotions. They were educational, informational, collegial exchanges between professionals, and those exchanges, which happened in physicians' offices and at dinner events and at medical conferences, began, covering territory that was considerably beyond epilepsy. Bipolar disorder, migraines, restless leg syndrome, chronic pain of various kinds, a range of psychiatric conditions for which the evidence that Neurontin helped was thin at best and in many cases essentially non-existent. The representatives were trained, according to internal documents that later surfaced in litigation, to use phrases like, "This is an all-purpose analgesic when discussing the drug with prescribers." That phrase, all-purpose analgesic, is doing a remarkable amount of work. It is turning a drug approved for one specific neurological condition into something that sounds like it belongs in every medicine cabinet for every occasion. Headache? All-purpose. Back pain? All-purpose. Anxiety that keeps you up at night? All-purpose. It is the pharmaceutical equivalent of telling someone that a hammer is a universal tool and watching what they do with their furniture. Medical education events, the kind where pharmaceutical companies arrange for physicians to attend dinner at a nice restaurant and hear a presentation from a colleague who is being paid by the company to present, were used as thinly veiled promotional vehicles. Ghost-written studies were placed in major medical journals under the names of academic researchers who'd sometimes done little more than review a draft and lend their institutional credibility to a document they had not written. Data that showed Neurontin did not work for certain conditions was buried. Data that suggested it did was amplified, published, and circulated. The information that reached physicians was not balanced. It was curated. In 2004, Warner Lambert, by then fully absorbed into Pfizer, pleaded guilty to criminal charges related to the illegal promotion of Neurontin and paid $430 million in fines. It was at the time one of the largest pharmaceutical fraud settlements in United States history, a number so large it sounds like accountability. And yet by that point the off-label prescribing had already become deeply embedded in clinical practice. Physicians who had spent years being told that Neurontin worked for condition X were still prescribing it for condition X, because the habit had formed and the information that formed it was already inside their heads, and the alternative required admitting they'd been systematically misled by people they had trusted. The lesson Pfizer took from all of this was do not do this. That would have been the lesson a different kind of organisation might have taken. The lesson was, be more careful about documentation and make sure the next drug has enough approved indications that the off-label promotion becomes less necessary and harder to prove. Lyrica, with its multiple FDA-approved indications across pain and seizure conditions, was designed from the ground up to operate inside wider legal boundaries. And it did, but the culture of expansive, aggressive prescribing that Neurontin had spent a decade normalizing was already embedded in the system that Lyrica walked into. The ground had been prepared. Lyrica just had to grow in it. Let's slow down for a moment and talk about the science. Not because this is a pharmacology lecture, it is not, and your pillow is right there, so stay with me, but because the actual mechanism of Lyrica is genuinely interesting, and understanding it is the only way to understand both why the drug works and why it causes the specific problems it causes. The two things are not separate. They come from the same place. Pregabalin binds to the alpha-2 delta subunit of voltage-gated calcium channels in the central nervous system. That is a very specific address. Picture your nervous system as an enormous, constantly humming electrical grid, and voltage-gated calcium channels as the switches that control how individual neurons fire. When a nerve cell receives a signal, whether that signal is pain, a seizure impulse, an anxiety loop that keeps restarting itself like a song you cannot get out of your head, calcium flows into the cell as part of the firing process. Pregabalin essentially reduces that calcium influx in neurons that are firing excessively. It does not turn the power off. It does not silence the system. Think of it like a governor on an engine. It does not stop the engine, but it prevents it from redlining. It keeps the system from going past the point where it starts causing damage to itself and to you. For people with diabetic neuropathy, this matters enormously. Diabetic neuropathy is what happens when high blood sugar, sustained over years, begins to damage the peripheral nerves, particularly in the feet and legs. Those damaged nerve fibers do not go quiet. They go loud. They fire constantly, chaotically, sending pain signals that have no meaningful relationship to what is actually happening in the tissue, burning, stabbing, electric shocks that arrive, without warning at 2 a.m, the sensation of walking on broken glass when you're standing on a flat floor. For a person living with this, pregabalin's ability to turn that volume down is not a small thing. It is the difference between sleeping and not sleeping, between working and not working, between a life that is manageable and one that is not. For people with post-herpetic neuralgia, the nerve pain that can persist for months or years after a shingles outbreak, Lyrica can reduce something relentless and exhausting to something livable. And for people with fibromyalgia, where the nervous system itself appears to amplify pain signals far beyond their original source, the calming effect of Lyrica can offer real improvement in daily function. These are real people with real suffering, and for many of them, Lyrica genuinely helped. That part of the story is important. It would be too easy and too dishonest to tell this as a story about a useless drug sold to unsuspecting people. That is not what happened. What happened is more complicated and in some ways more troubling than simple uselessness. Lyrica works for specific conditions in specific populations at appropriate doses with appropriate monitoring and for appropriate durations. The problem is that appropriate is a word that got loosely defined very quickly once commercial forces entered the picture, and the side effect profile of a drug that calms down the entire central nervous system is not trivial. Drowsiness, dizziness, weight gain, peripheral edema, swelling in the hands and feet that some patients found significant, blurred vision, and cognitive blurring. The sensation patients describe as thinking through wet concrete, as trying to find a word that keeps moving just out of reach, as not quite being present in your own mind in the way you used to be. Less discussed in the early years, and most consequential over the long term, was the dependence profile. The same mechanism that makes pregabalin effective, its suppression of calcium channel activity in overexcited neurons, also means that the nervous system, given enough time, begins to compensate. It upregulates. It produces more of the channels that are being suppressed. It tries to restore its own equilibrium. And when the drug is removed, those compensatory changes do not disappear overnight. They are still there. The nervous system that had been calmed crashes back upward. The drug works. The question was always whether it was being given to the right people, for the right reasons, in the right context. And that question, for a long time, nobody in a position of commercial influence was particularly eager to ask out loud. In 2007, something happened that dramatically expanded Lyrica's potential market. It became the first drug ever approved by the FDA specifically for fibromyalgia. And that approval was both a legitimate milestone worth acknowledging and the beginning of a very complicated chapter worth examining carefully, because both things are true at once, and collapsing either one loses something important. Fibromyalgia is a real condition. Let's be absolutely clear about that, because the history of fibromyalgia is already burdened with decades of medical skepticism, of patients, women in particular, and this is not a coincidence, being told that their pain was psychosomatic, that it was in their heads, that if the scans came back clean then there was nothing wrong, that perhaps they needed to exercise more, sleep better, stress less, as though the problem was a lifestyle choice rather than a nervous system that was doing something genuinely abnormal. The condition involves widespread musculoskeletal pain, fatigue, sleep disruption, and cognitive difficulties, and the evidence strongly suggests it involves a process called central sensitization, in which the nervous system itself amplifies pain signals far beyond their original source. The volume is turned up everywhere all the time, and there is no obvious external cause, which is exactly what made it so easy to dismiss. So when Pfizer received FDA approval for Lyrica as a fibromyalgia treatment, It carried an implicit message that many patients found meaningful. This condition is real. It is recognized. It is worth treating. And here is something that may help. A major pharmaceutical company had run clinical trials. A regulatory agency had reviewed the data and issued approval. For patients who had spent years not being taken seriously by the medical system, that institutional validation was not nothing. It mattered. But the approval also opened a door. Fibromyalgia affects an estimated 10 million people in the United States alone. Some estimates put the global prevalence at 2 to 4% of the population. That is an enormous potential market, and Pfizer understood this with the precision of a company that had spent decades learning how to read a patient population. The direct-to-consumer advertising campaign that followed was remarkable in its reach and in its craft. The television advertisements were soft and warm. A woman who'd been limited by pain, who had watched from the window while her grandchildren played in the yard, who had declined invitations because she did not know how she would feel, was now in the yard. She was gardening. She was laughing. Lyrica was framed not as a powerful central nervous system drug, with a significant side effect profile requiring careful monitoring, but as a gentle enabler of the life you used to have and could have again. The campaign worked in the way that well-crafted advertising aimed at people in genuine pain tends to work, immediately and broadly. Prescriptions surged. General practitioners who had previously felt uncertain about how to treat fibromyalgia patients, who had perhaps not had a clear protocol, who had perhaps referred these patients to specialists and watched them come back without a clear plan, now had something simple to reach for. Rheumatologists, neurologists, pain specialists were fielding patient requests from people who had seen the advertisement and recognized themselves in it. And while many of those patients genuinely benefited, the broad consumer-facing campaign created a population of Lyrica users who had made a decision, a medical decision, partly on the basis of 60 seconds of television and partly on the relief of finally feeling seen. What they were not told in those 60 seconds, or in many of the conversations that followed, was what they were consenting to for the long term. They were told about dizziness, about drowsiness, about not driving until they knew how the medication affected them. They were not told, with the same clarity and the same emphasis, that stopping this medication after months or years of use could be a significant and difficult process, and that planning for that eventuality should probably begin at the same appointment where the prescription was written. That conversation was not part of the campaign. It is not a conversation that sells anything. Here is where the story gets uncomfortable. Not because Lyrica's side effects were hidden, they were listed as required by law in every piece of prescribing information and in every advertisement. The law was followed. The boxes were checked. But there is a significant difference between legal disclosure and genuine informed consent, and that gap was, for a long time, wide enough that a very large number of people walked through it without knowing the ground had changed beneath them. The most common side effects of Lyrica, dizziness, drowsiness, weight gain, peripheral edema, blurred vision, were well documented and widely known among prescribers. Patients were told to expect some of these. They were advised not to drive or operate heavy machinery until they knew how the medication affected them, a warning so standard in CNS drug, prescribing that it had become, for many patients, the verbal equivalent of the terms and conditions page on a software update. Acknowledged, not read. These were manageable warnings for a medication with genuine therapeutic value, and they were delivered with the brisk confidence of things that are true but not expected to change the outcome of the conversation. But other conversations were happening more slowly and much more quietly. Reports of cognitive impairment, not just the mild drowsiness the label described, but significant memory loss, difficulty concentrating, the sensation of having a thought and watching it dissolve before it could be expressed, were accumulating in adverse event reports and in patient forums at a pace that outstripped their movement into clinical practice guidelines. Patients were describing something that felt not like a side effect but like a diminishment, a narrowing of the self, a fog that did not lift with coffee or with time, a growing uncertainty about whether the person they were becoming on the medication was the same person who had agreed to take it. Reports of mood changes were similarly underemphasized in the conversation between prescribers and patients. Lyrica's prescribing information includes a black box warning, the FDA's most serious level of safety communication, about the increased risk of suicidal thoughts and behaviors associated with anticonvulsant medications as a class. Black box warnings exist because the risk is real and because regulators determined it needed to be prominently disclosed. But a black box warning is on the inside of a package insert. It is not in the television advertisement between the woman and her garden. It is not the first thing said in the exam room. It lives in documentation that most patients never read and that physicians, working through 12-minute appointments with full waiting rooms, did not always revisit after the initial prescription was written. And then there was the issue of dependence, the one that would eventually become the loudest part of the story, though it took years for the volume to reach the level the situation warranted. Lyrica produces in some patients a feeling of mild euphoria, warm, soft, pleasant. This is partly why it became a drug of misuse in certain populations, and partly why regulators in several countries eventually moved to reclassify it. But more significant for the patients who were never misusing it, who were simply taking their prescribed dose at their prescribed times for their prescribed condition, was the discovery that stopping was not as simple as not refilling the prescription. Insomnia, anxiety that arrived at a severity they had not experienced before taking the medication, sweating, shaking, nausea, gastrointestinal distress, and in some cases seizures, a cruel and almost absurd irony for a drug that had originally been prescribed partly because of its anticonvulsant properties. The nervous system that had been suppressed for months or years did not simply return to its previous baseline when the suppression was removed. It overcorrected. It went in the other direction with a force proportional to how long it had been held down. The side effect conversation that nobody was having was not about dizziness. It was about what came after. For years, the question of Lyrica dependence was discussed primarily in patient communities, forums, support groups, message boards, Reddit threads populated by people who had come looking for answers that their physicians had not been able to provide, comparing notes on how to taper off a medication that had, quietly and without announcement, made itself essential to the functioning of their nervous systems. These were not formal clinical spaces. They did not have peer review or institutional oversight. They had something else. People who had been through it, who had documented their experience with painstaking detail, and who were sharing what they had learned because nobody else was sharing it with them. Doctors, in many cases, were not leading these conversations. They were receiving them. Patients who had been on Lyrica for years, not misusing it, not taking more than prescribed, just managing chronic pain exactly the way their physician had told them to, were arriving at appointments and explaining that they had tried to reduce their dose and that something had gone very wrong. Their bodies had adapted to the drug's presence in a way that had not been explained to them when the prescription was written. The calcium channels that Lyrica had been suppressing had, over time, upregulated, produced more of themselves in response to the suppression, the nervous system's attempt to restore its own equilibrium. When the suppression was suddenly removed, those overabundant channels opened all at once, and the system that had been calmed for months crashed back upward like a spring that had been held compressed and then released. The withdrawal experience, as described by patients in these communities, was not subtle and it was not brief. It was not a few uncomfortable days of mild symptoms that resolved with adequate hydration and rest. For some people, it lasted weeks. For others, months. The anxiety it produced could be more severe than any anxiety the person had experienced before starting the medication, which created a particularly vicious loop. The anxiety of withdrawal felt like evidence that the original condition had returned and was now worse, which led some patients, and some of their physicians, to conclude that the drug was necessary after all, and to restart it, when in fact what was happening was withdrawal from the drug itself. The insomnia was profound. Not the ordinary difficulty sleeping of a stressful week, but the specific, relentless wakefulness of a nervous system that has lost the tool it had been using to settle itself asleep and does not yet know how to do it alone. By the mid-2010s, regulators in the United Kingdom had begun taking formal notice. The data was accumulating in ways that were difficult to interpret as anything other than a significant population-level problem. Reports of dependence, misuse, and overdose involving pregabalin had been climbing steadily through the years following its wide adoption. In 2017, the UK's Advisory Council on the Misuse of Drugs recommended that pregabalin be reclassified as a controlled substance under the Misuse of Drugs Act. In 2019, that reclassification came into effect. The prescription now required a written, non-repeatable order. The casual telephone refill that had sustained years of continuous prescribing for patients who perhaps should have been reassessed and tapered was no longer available. The friction had been deliberately increased. In other countries, similar conversations were happening at various speeds and with various degrees of urgency. The European Medicines Agency updated its risk communications around pregabalin. The FDA in the United States added new prescribing information addressing misuse and dependence, language that acknowledged what patient communities had been documenting for years. The regulatory apparatus was catching up, as it tends to do, slowly, methodically, in the way that large institutional processes catch up to things that smaller, faster, more motivated groups of people have already understood. The patients in the forums had been right. The drug was harder to stop than anyone had been told, and it had taken the official machinery years to say so. The term Coffin tablet did not emerge from a medical journal. It did not appear in a regulatory document or a clinical trial report or a pharmaceutical company's post-marketing surveillance summary. It emerged from patients. Specifically, it emerged in the United Kingdom, where pregabalin had been prescribed at very high rates across a broad population and where the drug's involvement in overdose deaths, often in combination with opioids or other substances that act on the central nervous system, had become a matter of genuine and growing public health concern. The name was not chosen with clinical precision. It was chosen with grief. The deaths were not always intentional. That is the part that made the name land with such weight, and that made the anger behind it so specific and so hard to dismiss. Lyrica is a central nervous system depressant. Opioids are central nervous system depressants. Benzodiazepines are central nervous system depressants. Alcohol is a central nervous system depressant. In a population of patients managing chronic pain, a population that, by the nature of chronic pain, frequently has comorbid depression, anxiety and sleep disorders, and that frequently uses multiple medications to manage these overlapping conditions, and that frequently uses alcohol in the same way that people who are exhausted and in pain tend to use alcohol, the combinations were not unusual. They were, in fact, nearly inevitable. And Lyrica potentiated opioids. It amplified their effect. A dose of an opioid that a patient's body had built tolerance to over months or years of prescribed use could become significantly more dangerous when pregabalin was added to the picture. The opioid did not change. The tolerance did not change. What changed was the pharmacological environment in which the opioid was operating, and in that changed environment, respiratory depression, which is how opioid overdose kills people, could occur at doses that had previously been safe. Patients who had been stable on opioid regimens for extended periods were dying when Lyrica was added to their prescriptions, not because anyone had done anything reckless or outside the bounds of normal clinical practice, but because the interaction had not been communicated with the same clarity and urgency as the therapeutic benefit. In Scotland, which tracked drug-related deaths with particular rigour and published data in ways that allowed researchers to identify patterns at the substance level, pregabalin became one of the most commonly identified drugs in overdose fatalities. It was not usually the only substance present. Polypharmacy, the combination of multiple drugs, was almost always the mechanism. But pregabalin was present with striking regularity, in numbers that could not be explained by its prescribing rate alone. The drug that had been marketed with images of women walking peacefully in morning light was appearing in coroners' reports with a frequency that demanded explanation. The name Coffin tablet was blunt. It was angry. It came from people who had lost someone, or who had almost lost themselves, or who had watched someone they loved spend years trying to get off a medication that doctors kept telling them was safe to continue. And while it was extreme, the vast majority of people taking Lyrica were not dying from it, and saying otherwise would be dishonest. The anger behind the name was pointing at something real. The gap between the drug's public image and its actual risk profile, particularly in combination with other substances that a chronic pain patient might reasonably be taking, had become wide enough to be unconscionable. The name was extreme. The situation that produced it was not. One of the quiet engines behind Lyrica's remarkable commercial success was the same force that had driven Neurontins before it: off-label prescribing. And if you have been paying attention, you will notice that this is where the story begins to loop back on itself in a way that is either deeply ironic or deeply unsurprising, depending on how charitable you're feeling toward the pharmaceutical industry on any given evening. Lyrica was approved for specific indications: diabetic neuropathy, post-herpetic neuralgia, fibromyalgia, spinal cord injury pain, and certain seizure disorders. These were the lanes the FDA had reviewed data for, found sufficient evidence in, and signed off on. The lanes were real. They were appropriate. But the prescribing information that accompanied the drug described its mechanism in language that made the leap to other conditions feel almost logical. A drug that calms overexcited nerves. A drug that reduces excessive neuronal firing. A drug that modulates the central nervous system's response to pain signals. Read that description slowly and ask yourself which chronic condition it does not sound potentially relevant to. The language was accurate. It was also, not accidentally, very broad. Generalized anxiety disorder was one of the most significant off-label uses. While Lyrica was approved for this indication in Europe, where the clinical trial data was reviewed and found sufficient, it was never granted that approval in the United States. The FDA reviewed the data and did not find it met the threshold for approval. That is a meaningful regulatory distinction. But meaningful regulatory distinctions do not always translate into meaningful clinical practice distinctions, particularly when a drug is already being prescribed by a large number of physicians who have been educated about its mechanism and who are facing patients with anxiety that benzodiazepines have either failed to help or that they are reluctant to prescribe because of the well-documented dependence problems with that class. The irony of substituting a drug with significant dependence potential for another drug with significant dependence potential was not always apparent in the moment of that clinical decision. Back pain was another enormous off-label category. In the United Kingdom, pregabalin was prescribed at extremely high rates for non-specific lower back pain, perhaps the most common pain complaint in the entire practice of medicine, affecting nearly everyone at some point in their lives and representing an enormous proportion of primary care. Consultations. The evidence that pregabalin helped with non-specific back pain was not strong. It was, in fact, largely absent. A major clinical trial published in the New England Journal of Medicine in 2019 found that pregabalin was no more effective than placebo for acute sciatica, a finding that did not go unnoticed and that prompted significant reassessment of prescribing guidelines in several countries. Sleep disorders, restless leg syndrome, alcohol withdrawal management, post-surgical pain control, headache. The list of conditions for which pregabalin was being prescribed grew steadily and quietly across the years of its commercial life, outpacing the evidence base in many cases and creating a population of long-term users who had been started on a drug with a significant dependence profile for a condition it had never been proven to effectively treat, and who would eventually discover what that meant when they tried to stop. Perhaps the most human dimension of the Lyrica story is not in the boardrooms or the regulatory agencies or the courtrooms, important as those spaces are. It is in the patient communities that formed, organically and out of necessity, because the medical system that had confidently prescribed the drug had almost nothing to offer the people who wanted to stop taking it. Online communities dedicated to pregabalin tapering grew substantially through the 2010s. They were populated by people who were not addicts in the way that word is commonly understood, people who had not sought out the drug recreationally, who had not escalated their doses seeking euphoria, who had not ignored medical advice or used the drug in ways that were not prescribed. They were people who had taken Lyrica exactly as their physician had directed, often for years, often for conditions that the drug was legitimately approved for, and who had been told at some point by a new physician, by a pharmacist reviewing their medication list, by a label that recommended not using indefinitely, that they should stop. And when they tried, they discovered that their nervous systems had quietly reorganized themselves around the drug's presence in a way that nobody had warned them about. The tapering schedules that emerged from these communities were slow, painstakingly, almost bureaucratically slow. Reductions of 10% of the current dose every few weeks, sometimes slower than that, sometimes much slower. The 10% figure did not come from an official clinical guideline. Most official guidelines at the time said almost nothing specific about how to taper pregabalin, because the clinical literature on the subject was sparse and the regulatory framework had not yet caught up to the scale of the problem. The 10% figure came from patients, comparing their experiences, documenting what worked and what produced intolerable symptoms, building an empirical knowledge base through collective painful experimentation that the medical system had not provided and was not yet equipped to provide. Physicians in many cases were unequipped to help, not because they did not care, but because nobody had given them the tools. The clinical literature on pregabalin withdrawal was sparse. The training programs that prepared physicians to prescribe the drug had not included equivalent training on how to discontinue it, and the symptom profile of pregabalin withdrawal, anxiety, insomnia, irritability, pain that had returned or worsened, looked very much like the conditions for which the drug had originally been prescribed, which created a diagnostic problem with real consequences. Patients reporting withdrawal symptoms were sometimes told that what they were experiencing was a return of their underlying condition, that their pain or anxiety had come back and was now worse, that the drug was clearly necessary and should be continued. This was both medically possible and, in many of these cases, wrong. Withdrawal and relapse are clinically different things. Confusing them resulted in patients being restarted on a drug that was making their situation worse, which extended the period of dependence, which made the eventual tapering process harder when it was finally attempted correctly. The communities persisted. They grew. They developed resources, tapering calculators, symptom timelines, accounts from people who had successfully reached zero and described what that felt like. They became, in the absence of adequate institutional support, the primary source of practical guidance for a population of patients that numbered in the millions and had been left, largely, to figure this out for themselves. In 2009, Pfizer reached what was at that time the largest healthcare fraud settlement in the history of the United States Department of Justice. $2.3 billion. Say that number slowly. $2.3 billion. It is the kind of number that sounds like consequence. It is the kind of number that sounds like someone, somewhere, is being held accountable in a way that will change behavior going forward. It is the kind of number that makes headlines and prompts editorial columns about the importance of regulatory enforcement and the principle that no corporation, regardless of size, is above the law. It is also, it turns out, the kind of number that a pharmaceutical company can absorb without fundamentally changing the practices that generated it. The settlement covered a range of marketing violations across multiple drugs, but Lyrica was among them. The allegations included promoting Lyrica for off-label uses in ways that violated federal law, and providing kickbacks to physicians in the form of speaking fees, consulting arrangements, and other financial benefits designed to encourage prescribing. These were not allegations that Pfizer disputed in any meaningful way. They pleaded guilty to a felony charge. The violations were real. The documentation was substantial, and the outcome was a negotiated settlement of a size that reflected the scale of what had occurred. This was not Pfizer's first such settlement, and it would not be their last. The company had previously settled charges related to Neurontin, the same genre of violation, the same structural playbook, a different drug. A pattern repeated across different molecules, different brand names, different patient populations, and different decades is not a series of isolated mistakes. It is a pattern, which means it reflects something about the way the system is designed, about what the system rewards and what it tolerates, and about what the financial calculus looks like when a company weighs the revenue from aggressive off-label marketing against the eventual cost of the settlement that aggressive off-label marketing will eventually produce. The math, when you do it, is clarifying. The $2.3 billion settlement sounds enormous. Lyrica alone generated more than $3 billion in revenue in 2012, a single year. That is before the patent ran until 2019, before the years of revenue that preceded and followed 2012. When you look at the total revenue that Lyrica generated across its commercial life and compare it to the fines paid for the marketing violations associated with its promotion, the settlement stops looking like a penalty and starts looking like a cost of doing business, a line item in a financial model that was calculated in advance and found acceptable. What the settlement did not include was any significant accountability at the individual level. No executives were imprisoned. No sales representatives who had been trained to describe a controlled substance candidate as an all-purpose analgesic faced personal legal consequence. No prescribers were required to examine the prescribing patterns they had adopted under the influence of a marketing campaign that had been found to violate federal law. The institutional knowledge that had generated the violations largely remained in place, and the patients who had been started on Lyrica for conditions it was never shown to effectively treat remained, in many cases, on it, still taking the drug, still unaware of the full picture, still waiting for a conversation about how to eventually stop that would not come until years later, if it came at all. The legal reckoning happened, the fine was paid, the press releases were issued, and then, largely, everyone went back to work. The United Kingdom's decision to reclassify pregabalin as a Schedule III controlled substance in 2019 was significant in a way that went beyond the practical changes it produced, though the practical changes were real and meaningful. It was significant as a signal, a formal, official, institutional signal that the position taken at the beginning of Lyrica's commercial life, that this was a broadly safe, medication appropriate for a wide range of chronic conditions across a wide range of patients, had been reviewed in light of the evidence, found to be inadequate, and officially revised. The reclassification came after years of data that, when viewed in aggregate, told a story that was difficult to interpret as anything other than a systemic problem. Pregabalin was appearing in overdose deaths with increasing and disproportionate frequency. It was being diverted, taken from prescriptions and sold or given to people for whom it had not been prescribed, partly because of the mild euphoric effect that some users found appealing, and the dependence profile in clinical populations, in patients who were taking the drug exactly as prescribed, was proving to be more significant and more difficult to manage than the early post-marketing surveillance had captured. Scotland's data was particularly stark. The National Records of Scotland tracked drug-related deaths at a level of granularity that allowed researchers to see which substances were present in which deaths, and pregabalin appeared in those records with a frequency that demanded a policy response. The reclassification meant that prescriptions could no longer be refilled without a new written order. It introduced friction into a process that had become, over years of routine practice, essentially frictionless. A physician who'd been authorizing repeat prescriptions by telephone or electronic message without seeing the patient could no longer do so in the same way. A patient who had been on pregabalin for years without a formal reassessment was now more likely to be seen, evaluated, and asked whether continued prescribing was still appropriate. This is not a revolutionary intervention. It is, in fact, a fairly modest one. But in a system where the absence of friction had contributed enormously to the scale of the prescribing problem, even modest friction had measurable effects. The United States took a different path. Pregabalin has not been reclassified at the federal level, though several individual states designated it as a Schedule 5 controlled substance, the lowest tier of federal controlled substance classification, signaling recognized abuse potential without imposing the stricter controls of higher schedules. The FDA updated prescribing information and issued communications addressing misuse and dependence. These were real changes. They were also less structurally significant than what the United Kingdom had done, reflecting a different regulatory philosophy and a different set of political and commercial pressures. The divergence between these approaches is instructive. It demonstrates that the scale of the Lyrica problem in any given country was not simply a function of the drug's pharmacology. The molecule was the same everywhere. It was a function of system design, of how prescribing decisions were structured, monitored, and revised, and of how willing each regulatory environment was to impose constraints on a commercially successful medication once the evidence of harm accumulated to a level that made inaction difficult to defend. It would be easy, having spent this much time walking through fraud settlements and withdrawal forums and coroner's data, to arrive at a clean conclusion. Lyrica was a bad drug pushed by a bad company onto unsuspecting patients. Full stop. End of story. That conclusion would be satisfying in the way that clean conclusions are satisfying. It would also be wrong, and honouring the full truth of this story, which is the only version of the story worth telling, requires sitting with the part of it that is genuinely, verifiably, meaningfully good. There are people alive today who, without Lyrica, would be living in a degree of pain that most people who have not experienced it cannot fully imagine. Diabetic neuropathy, left untreated or inadequately managed, is not merely uncomfortable. It is a profound, relentless interference with the basic functioning of daily life. The burning, stabbing, electric shock sensations that damage peripheral nerves produce, particularly in the feet and legs, where diabetic neuropathy tends to concentrate, do not pause for meals or conversations or the arrival of visitors. They do not grant a few hours of relief at night. They are constant, chaotic, and disproportionate to anything happening in the tissue they claim to be reporting on. For a person living with this, the nervous system has become an unreliable narrator, screaming pain into a body that is not in the danger the signals suggest. Lyrica, for many of these patients, turned that screaming down to something manageable. Not silence. Chronic pain rarely reaches silence, but something that allowed sleep, that allowed the completion of a thought, that allowed a walk to the kitchen without dread. That is not a small thing. Post-herpetic neuralgia carries a similarly heavy burden, and it carries it in a population that is often older, often already managing other conditions, and often desperately in need of something that works. The pain that can persist after a shingles outbreak, sometimes for months, sometimes for years, is in a category that people who have not experienced it struggle to understand from the outside. It is not a headache that ibuprofen addresses. It is not soreness that a night of good sleep improves. It is a neurological misfiring that produces sensations so constant and so intense that it has driven patients to despair, to withdrawal from social life, to the kind of exhaustion that comes from fighting pain every waking hour. For some of these patients, Lyrica provided relief that nothing else had. That matters. These stories exist alongside the other stories in this history. They do not cancel each other out. The patient whose fibromyalgia was legitimately, meaningfully helped by Lyrica, and the patient who developed severe physical dependence on a drug prescribed for back pain it was never proven to help. Both of these people are real. Both of their experiences happened within the same system, and both of them deserve to be part of the telling. The pharmaceutical system served one of them and failed the other. Understanding how it managed to do both simultaneously, with the same drug, in the same years, is the uncomfortable heart of the story. It is not a story of pure villainy. It is a story about what happens when a genuine tool is placed inside an environment shaped by commercial incentives, regulatory gaps, prescribing habits formed under the influence of marketing, and the deeply human desire on the part of both patients and physicians to find something that actually helps. That environment did not serve everyone equally, and the people it failed deserved better. In the United States, pharmaceutical companies are permitted to advertise their products directly to consumers through television, print, and digital media. This is not true in most of the world. It is in fact permitted only in the United States and New Zealand among countries with developed pharmaceutical markets, a distinction that most other developed nations made deliberately and have maintained deliberately, on the grounds that the practice creates pressure on prescribing decisions in ways that do not reliably serve patient welfare. The United States made a different decision, and the Lyrica campaign is one of the clearest illustrations of what that decision looks like in practice. The advertisements were warm. They were beautifully produced and carefully, almost clinically, calibrated to speak directly to a patient population that had, in many cases, spent years feeling invisible to the medical system. The fibromyalgia patient who'd been told by multiple doctors that her pain was psychological, who had watched people around her struggle to believe that something real was happening in her body, who had felt the particular exhaustion of fighting not just the pain itself but the skepticism of the people who were supposed to help, she recognized herself in the woman in the Lyrica advertisement. The woman on screen was her. The gardening was what she used to do. The grandchildren playing in the yard were her grandchildren. The advertisement did not sell her a drug. It sold her a recognition, and then offered the drug as the mechanism by which the recognition became recovery. And then she went to her physician and asked about Lyrica. This is the explicit, stated purpose of direct-to-consumer pharmaceutical advertising, and study after study has confirmed that it achieves its purpose. Patients who see an advertisement for a drug and then ask their physician about it are more likely to receive a prescription for that drug, even in cases where the physician's initial clinical assessment was that the drug was not the most appropriate choice for that patient's specific presentation. The physician who has an alternative in mind now has additional work to do, explaining that alternative, explaining why the advertised drug is not the recommendation, and doing this in an appointment slot that is typically 12 minutes long, with a patient who has come in with a specific hope and a specific expectation. That explanation does not always happen, and when it does not, the prescription that results is shaped at least partly by an advertisement, rather than purely by clinical judgment. The advertisements were legally required to include a fair balance of information about side effects, and they did. Every television advertisement for Lyrica included a recitation of side effects: dizziness, drowsiness, weight gain, swelling of hands and feet, blurred vision, difficulty concentrating, suicidal thoughts. The list was real. It was complete. It was delivered by a voice speaking at a pace that was brisk enough to meet the regulatory requirement without disrupting the emotional warmth of the 60 seconds that preceded it. The woman with fibromyalgia walking her dog at sunset was the image. The side effect recitation was the audio track run underneath it, spoken at the speed of something you were not expected to process, in a format that decades of pharmaceutical advertising had trained viewers to understand as the routine legal obligation at the end, rather than the information most relevant to their decision. The disclosure was present. The communication was not. Lyrica's main patent in the United States expired in 2019, and the arrival of generic pregabalin changed the commercial landscape around the drug in ways that were real, meaningful, and in some respects considerably more complicated than the simple narrative of generics as straightforwardly good news would suggest. On the most straightforward level, the arrival of low-cost generic pregabalin was genuinely positive for patients who needed the medication and for whom it was appropriate. The brand name Lyrica had been expensive. Prior authorization requirements, the process by which insurers require physicians to document that a prescribed drug is medically necessary before approving coverage, had created barriers and delays for some patients with legitimate clinical needs. A $5 generic removes those barriers in a way that a $60 brand name copay does not. For the patient with diabetic neuropathy, who has already tried other treatments, who has already been through the prior authorization process, who simply needs the medication to be affordable enough that they can take it consistently, the generic era was unambiguously better. But the lower cost of generic pregabalin also meant that the friction that high price had previously created around off-label prescribing was reduced. A physician who had, for reasons of cost or formulary access, hesitated before prescribing Lyrica for an indication that was not FDA approved now had less reason to hesitate. The drug was cheap. The refill was easy. The conversation about whether this was the right drug for this patient, for this condition, for this duration, could be deferred again, and in a system where that conversation had rarely been held with sufficient depth, even when the drug was expensive, the removal of the cost barrier did not produce the reflective pause that a more deliberate system might have built in. The commercial incentive that had driven Pfizer's extraordinary investment in physician education and direct-to-consumer advertising was gone. Generic manufacturers do not run fibromyalgia awareness campaigns. They do not fund speaker bureaus or medical education events, or the continuing medical education that keeps a drug's name and mechanism in the front of prescribers' minds. The aggressive marketing infrastructure that had shaped pregabalin's prescribing culture for 15 years had departed. But prescribing cultures, once shaped, do not reshape themselves simply because the shaping force has withdrawn. Habits are durable. They outlast the campaigns that formed them. The physicians who had been prescribing pregabalin broadly for a decade did not receive a notification in 2019 informing them that the commercial rationale for that prescribing had changed. They continued largely as they had been. The pharmacovigilance infrastructure, the systems by which a drug's safety in the real-world population is monitored after it reaches market, also became more complex in the generic era. With multiple manufacturers producing the same molecule, the responsibility for post-marketing surveillance was distributed in ways that created gaps. This is not unique to pregabalin. It is a structural feature of how generic pharmaceutical markets operate. But for a drug with a complex and still evolving safety profile, the distribution of that responsibility across entities with varying levels of investment in the outcome was not a reassuring development. The molecule had not changed. The need to watch it carefully had not diminished. What had changed was who was responsible for the watching and how motivated they were to do it well. To tell this story honestly, you have to spend some time inside the clinical reality that physicians were navigating, because one of the ways this story can be misread is as a story about doctors who were careless or complicit, who prescribed a problematic drug to large numbers of patients and looked the other way. That is not, in most cases, what happened. What happened is more structural than that, and more troubling in some ways, because structural problems are harder to fix than individual failures. When Lyrica first became widely available in the mid-2000s, prescribers were working within a genuinely difficult landscape for chronic pain management. The opioid crisis was playing out simultaneously and with devastating effect, and the response to that crisis, the gradual tightening of opioid prescribing, guidelines, the increasing reluctance of physicians to maintain patients on long-term opioid therapy, the pressure from regulatory bodies and insurers to reduce opioid prescription volumes, had created a situation in which patients with real, significant chronic pain needed alternative options, and the options that existed were limited and imperfect. Into this landscape, Lyrica arrived with FDA approval for multiple pain conditions, with the institutional backing of the world's largest pharmaceutical company, with a mechanism of action that made theoretical sense for a range of neuropathic conditions, and with clinical trial data demonstrating measurable benefit in appropriate populations. The continuing medical education that physicians received about pregabalin, much of it funded directly or indirectly by Pfizer, was generous, accessible, and focused almost entirely on the therapeutic case for the drug. It covered the mechanism, the approved indications, the clinical trial, results, the patient populations most likely to benefit. It did not cover, with equivalent emphasis or depth, the questions that would become most consequential over time: how to identify patients at elevated risk of dependence, how long a course of treatment was appropriate before reassessment, how to monitor for the emergence of withdrawal-like symptoms in patients who tried to reduce their dose, and how to support patients through discontinuation when the time came. This asymmetry was not accidental. It reflected the commercial priorities of the organization funding the education. Teaching a physician why to start a drug generates prescriptions. Teaching a physician how to safely stop a drug does not. The investment went where the revenue was, which is a description of how pharmaceutical-funded medical education tends to work, not an indictment of any individual physician who attended a dinner event and absorbed what was presented. A physician prescribing Lyrica for a patient with fibromyalgia in 2008 was following a legitimate guideline-supported treatment path. They were not doing something reckless or outside the norm of clinical practice. What they were not given, by the prescribing information, by their training, by the educational resources available to them, was a clear and equally weighted accounting of what a 2-year, 5-year, or decade-long course of treatment meant for the nervous system, and what the patient would face if they eventually needed to stop. That conversation, had it happened at the beginning, would have changed things. It did not happen at the beginning, at scale, because nobody with the resources to make it happen had the incentive to make it happen. The opioid crisis is the defining story of pain management in the early 21st century, and Lyrica exists in a relationship to it that is complicated, under-examined, and in some respects deeply ironic. because Lyrica was, in the years of its aggressive promotion, positioned partly as a solution to the opioid crisis, a non-opioid option for patients with chronic pain that could reduce the burden on opioid prescribing and offer relief without the dependence and overdose risks associated with opioids. That positioning was not entirely dishonest. Pregabalin is not an opioid. It does not act on opioid receptors. Its mechanism is genuinely different, and for some patients, it provided pain relief that reduced their need for opioid medication. The positioning had a factual basis. What the positioning did not fully account for was the pharmacological reality of what happens when pregabalin and opioids share a bloodstream. Both drugs act on the central nervous system. Both produce, as a dose-dependent effect, respiratory depression, a slowing of the breathing that, at sufficient levels, becomes life-threatening. When these two depressants are combined, their effects are not simply additive. They can be synergistic, meaning the combined effect is greater than the sum of the individual effects. A dose of an opioid that a patient's body had built tolerance to over months or years of prescribed use could become significantly more dangerous when pregabalin was present. The opioid had not changed. The tolerance had not changed. The pharmacological environment in which the opioid was operating had changed in a direction that increased risk in ways that were not always communicated to the patients or to the prescribers adding pregabalin to existing regimens. In patient populations managing chronic pain, co-prescription of pregabalin and opioids was extremely common. This was not irrational. Many chronic pain patients have complex multifactorial conditions that do not respond fully to a single medication, and combining drugs with different mechanisms to address different components of the pain experience is a reasonable clinical strategy. But the monitoring required to do this safely, close follow-up, attention to respiratory symptoms, careful attention to everything else the patient was taking, including over-the-counter medications and alcohol, explicit conversations about what to watch for and when to seek help, was not always provided. Partly because appointment times were short, partly because the interaction, while disclosed in prescribing information, had not been communicated with the urgency that the mortality data would eventually reveal was warranted. The coroner's data in the United Kingdom told a story that was difficult to look away from once you started looking. Pregabalin appeared in overdose deaths, with a frequency that exceeded what its prescribing rate alone would predict, which is a statistical signal that the drug was contributing to deaths, rather than simply being present in the bodies of people who died from other causes. It was not usually the only substance. It was almost always part of a combination, and the combination, in case after case, included an opioid. The drug presented as part of the solution to the opioid crisis was, in practice, multiplying the risk of the crisis's most visible and irreversible outcome. That is not an argument against using pregabalin in combination with opioids in appropriately monitored patients. It is an argument for the monitoring actually happening consistently at a level commensurate with the risk. One of the most illuminating dimensions of the Lyrica story, the dimension that perhaps most clearly demonstrates that what happened was not simply the inevitable result of the drug's pharmacology, is how differently the story played out in different countries, under different regulatory frameworks, inside different healthcare systems. The molecule was the same everywhere. The mechanism was the same. The side effect profile was the same. What differed was the system surrounding the molecule, and those differences produced measurably different outcomes for patients. Australia's pharmaceutical benefit scheme provides one of the clearest examples. The PBS, which subsidises medications for Australian citizens, required that pregabalin prescriptions meet specific documented criteria before the subsidised price would apply. A physician prescribing pregabalin for an approved indication needed to document that the patient had an appropriate diagnosis and that alternative treatments had been tried and found insufficient. This created friction, Not insurmountable friction, not the kind of friction that prevented patients with genuine need from accessing the medication, but enough friction that a prescription written casually for a condition that was not approved, for a patient who had not yet tried other options, was less likely to make it through the process unchallenged. The kind of casual off-label prescribing that a brief patient request and a 12-minute appointment could generate in an unstructured system was harder to sustain when the prescriber had to document clinical justification. Some European systems required specialist review before certain pregabalin prescriptions would attract coverage, introducing a second clinical opinion into a decision that in other markets was made entirely by a single general practitioner in a brief consultation. Canada's provincial plans had varying levels of restriction that produced varying levels of prescribing intensity across the country's different regions. Japan's pharmaceutical market operated according to different prescribing norms and tracked adverse events through a national database with a rigour that contributed to earlier updating of guidance than some other countries achieved. None of these systems were perfect. Patients with legitimate clinical needs sometimes faced delays or denials that were frustrating and consequential. Bureaucratic friction can cause harm as well as prevent it, and acknowledging that the frictionless prescribing culture of the United States and United Kingdom created problems does not mean that maximum friction is the answer. But the international comparison makes something important visible. The scale of the Lyrica problem in the countries where it was most severe was not determined by the drug. It was determined by the system the drug operated within. The same molecule in a different system produced a different outcome. That means the outcome was changeable. That means it was, to a significant degree, preventable. And that is perhaps the most important and most uncomfortable thing the international comparison shows us. There are people, many of them, more than the clinical literature at the time would have helped you find, more than the official guidance acknowledged, who took Lyrica for years, developed significant physical dependence, went through the slow and difficult and often lonely process of tapering off, and came out the other side. Their accounts do not make headlines. They are not the data points in coroner's reports or the subjects of regulatory enforcement actions. They are ordinary people who went through something that turned out to be much harder than anyone had prepared them for, and who navigated it largely without institutional support, and who are, on the other side, largely fine. Their stories matter, not because they minimize the suffering of those who had worse outcomes, but because they are part of the full picture, and the full picture is the only honest one. They describe, most commonly, a process that required a quality of patience they had not previously needed to call on. Months of careful, incremental dose reduction. Weeks at a dose that felt stable before attempting the next reduction. The management of symptoms that emerged with each reduction, not always severe but always present, always requiring attention, always representing the nervous system's protest at having something removed that it had come to depend on. The patience required is not metaphorical. It is literal, specific, daily. You wake up and you take the smaller dose and you notice the difference and you wait for the next few weeks to pass before you take the smaller dose again. They describe the support of online communities in terms that make clear how significant that support was and how absent equivalent support was from formal clinical channels. Forums where people who were 6 months ahead of them on the tapering journey could say, "This is what the next month feels like. This is what helped. This is what made it worse." This kind of knowledge, embodied, experiential, specific to the process of coming off this particular drug, was not available in clinical guidelines. It was available from people who had done it. And finding those people, in the absence of institutional resources, was what made the difference for many of the people who successfully navigated the process. They also describe frequently, and with a specificity that is worth attending to, a quiet and particular anger. Not the dramatic anger of someone who feels They have been catastrophically wronged, though some of them feel that too. The quieter anger of someone who was not given information they needed to make a decision, who made the decision without it, who lived with the consequences of the gap, and who eventually came to understand clearly what had been withheld and why. The consent they gave to beginning treatment did not include meaningful information about the commitment involved in that decision. And when they went looking for guidance on how to honour that commitment in reverse, how to end the treatment safely, they found that the system that had been so forthcoming about why to start had almost nothing to say about how to stop. That anger is specific. It is earned. And it is the anger not of people who want to see medicine dismantled, but of people who believed in it enough to trust it, and who found that trust was not fully reciprocated. Pregabalin is still prescribed. It is still, for the right patients, in the right clinical context, with the right monitoring and the right plan for eventual discontinuation, a meaningful medication that offers real relief for real suffering. The diabetic neuropathy patient who finally sleeps through the night because a relentless and chaotic pain signal has been turned down to something manageable. That patient's experience is real, and it matters, and it should be part of how we think about this drug in 2025 as much as it was part of how we thought about it in 2005. But the landscape around the drug has changed, and the changes are real and in the direction of greater caution, greater specificity, and greater honesty about what long-term use involves. Prescribers are more careful, not universally, not perfectly, but measurably more careful than they were a decade ago. Clinical guidelines in multiple countries have been updated to reflect a more nuanced view of who should receive pregabalin for what duration, with what monitoring, and with what plan for discontinuation built in from the beginning of treatment, rather than addressed when the patient asks about stopping years later. The United Kingdom's reclassification has changed the practical architecture of prescribing in a way that has reduced casual repeat prescribing without, in the data available so far, producing major access problems for patients with genuine clinical need. Patient communities have built repositories of information about tapering and withdrawal that did not exist 15 years ago, and some of that community-generated knowledge has begun, slowly, through the particular channels by which patient experience eventually influences clinical practice, to appear in clinical guidance. The people who spent months in online forums comparing reduction schedules and documenting symptom timelines were doing something that looked informal, but was, in practice, the early stages of an empirical knowledge base. That knowledge base is now informing, in some places, the guidance that physicians receive about discontinuation. The pharmaceutical industry's relationship with the drug has changed in a way that reflects the economic reality of the post-patent era, rather than any particular moral reckoning. Pfizer no longer has the patent revenue incentive that drove 15 years of aggressive marketing investment. Generic manufacturers, operating on narrower margins in a competitive market, do not run fibromyalgia awareness campaigns or fund speaker bureaus or sponsor continuing medical education events built around the therapeutic case for their molecule. The advertising has stopped. The prescribing culture it created has not fully stopped with it. Habits are more durable than the campaigns that form them, but it is changing gradually as new physicians trained under updated guidelines replace those trained under the older ones, and as the accumulated evidence of what broad prescribing produced becomes part of the story that is told about the drug. The Coffin tablet name persists in the communities where it was coined, as names do when they attach to something that has caused genuine harm. It is blunt, and it is extreme, and it represents the experience of a specific population of people for whom the drug's risk profile was not what they were told. That name, and the people behind it, are part of the story. They always will be. Every pharmaceutical scandal, if you wait long enough and document it carefully enough, eventually becomes a lesson. The question that history consistently asks and that history consistently reveals the uncomfortable answer to, is whether the lesson actually penetrates the practices it was supposed to change, or whether it remains neatly contained inside policy documents and settlement agreements and regulatory guidance updates, while the structural forces that generated the problem continue operating, largely undisturbed, on the next molecule. Lyrica taught, or should have taught, that the lessons of Neurontin had not been learned. This is perhaps the most damning single observation in the entire story. Neurontin had already demonstrated, in considerable detail and at the cost of enormous patient harm, what happened when commercial incentives were allowed to shape clinical education at scale. The off-label promotion, the ghost-written literature, the speaker bureaus, the selective publication of trial data, the cultivation of prescribing habits that outlasted the evidence base that was supposed to justify them. All of this had already happened, had already been litigated, had already produced a settlement, and had already generated the kind of public documentation that should have made repetition impossible. And then it was repeated, with the same company, with the same structural playbook, with the same outcome for patients, and a larger settlement check at the end. If Neurontin was a warning, Lyrica was proof that the warning had not been heeded. Lyrica taught, or should have taught, that direct-to-consumer advertising for medications with significant dependence profiles is a public health problem that disclosure requirements cannot adequately address. The gap between an emotionally compelling 60-second advertisement and the clinical reality of long-term central nervous system suppression is not a gap that a quickly recited list of side effects can bridge. Information that is present is not the same as information that is communicated, and communication that is designed to minimize the emotional impact of risk information delivered at speed, at the end, after the aspirational imagery has done its work, is not the same as informed consent. The architecture of pharmaceutical advertising in America is designed to sell. It is not designed to inform. Treating those two things as equivalent has costs, and those costs are borne by patients. Lyrica taught, or should have taught, that the post-marketing surveillance system, the mechanism by which a drug safety in the real population is monitored and acted upon after it reaches market, needs to operate at a speed and with a responsiveness that it currently does not achieve. The withdrawal problem was visible in patient communities years before it was visible in clinical guidelines. That lag is not a minor administrative inconvenience. It is a period of time during which millions of people were being prescribed a drug without adequate information about a risk that was already being documented, discussed, and measured in the communities of people experiencing it. Closing that lag, building systems that are as quick to detect and respond to population-level harm signals as they are to approve and promote new treatments, is a policy choice. It requires investment and political will. The Lyrica story is one argument among many for making that investment, and Lyrica taught, or should have taught, that informed consent is not a form. It is a conversation, a real one, with adequate time and honest content about what the drug does, what it can cause, what stopping it involves, and what happens if the treatment needs to end. That conversation, for pregabalin patients, did not happen at scale, and the absence of that conversation is, more than any other single factor, where the harm that was preventable lived. No account of Lyrica is complete without sitting, for a moment, with the people who cannot be here to tell their own stories. The people who appear in the Scottish mortality data as a number in a column. The people whose families spent years trying to understand how a prescription written by a physician they trusted, for a condition that was real, became part of the mechanism of a death they did not see coming and could not explain. These deaths were not uniform in their nature or their cause, and it would be dishonest to flatten them into a single story. Some involved deliberate self-harm by people whose pain, physical, emotional, or both, had, reached a point that the medication had not adequately addressed and that the medical system had not adequately supported. Lyrica's prescribing information notes the increased risk of suicidal ideation associated with anticonvulsant medications as a class, and people living with chronic pain have elevated baseline rates of depression and suicidal ideation that exist independently of any medication. The intersection of these factors, in people who were not being closely monitored, produced outcomes that were not inevitable and were not adequately anticipated. Some involved accidental overdose, where the combination of pregabalin with opioids or benzodiazepines or alcohol produced a degree of respiratory depression that the person did not intend, and that no one in their life had been equipped to anticipate or prevent. These were not people who had done something reckless. They were people managing multiple conditions with multiple medications in a healthcare system that had prescribed each medication individually without always considering the combined pharmacological picture. They had not been told with sufficient clarity that the combination they were living with was meaningfully more dangerous than the sum of its parts. The families of these people have in many cases found ways to carry what happened forward rather than simply carry it. Not always through public advocacy. Grief is not always extroverted, and there is no obligation on a family that has lost someone to become a spokesperson for policy change. But many of them have changed something in their immediate world. They have talked to their own physicians differently. They have asked questions they did not know to ask before. They have shared what they learned with people around them who are taking similar medications or who are family members doing so. This transmission of knowledge, quiet, personal, moving through the informal networks of family and community, is slower than regulatory action and less visible than litigation. But it reaches places that neither of those mechanisms reaches, and it carries a credibility that no policy document can replicate. These families did not choose to become part of this story. They were placed in it by decisions made in clinical offices, in boardrooms, and in regulatory agencies that were managing populations and probabilities and had not yet resolved the specific person at the specific intersection of specific risks into the statistics those decisions would eventually produce. They deserve to be named in the telling, even without their names. They are the reason the history matters. One of the questions that surfaces in pharmaceutical policy discussions about cases like Lyrica, and that deserves a serious answer rather than a dismissive one, is whether the drug could have been designed from the beginning or reformulated early in its commercial life with stronger structural safeguards against the dependence and misuse that eventually defined its most controversial chapter. It is a question that sounds almost naive when you ask it out loud, because the answer might seem obvious from a commercial standpoint. But the question is genuine, and the answer is complicated, which is usually a sign that it is worth asking carefully. The pharmacology of pregabalin is not infinitely malleable. The mechanism that makes it effective, its binding to the alpha-2 delta subunit of voltage-gated calcium channels, its suppression of excessive neuronal firing, also produces the central nervous system effects that generate the pleasant sensation some patients describe and that drive both therapeutic adherence and, in some populations, misuse. You cannot remove the CNS effects from the molecule without removing the mechanism that produces the therapeutic benefit. The molecule does not come apart that cleanly. A drug that calms an overexcited nervous system is going to calm the nervous system, and that calming is going to feel like something to the person experiencing it. That is not a design flaw, it is a pharmacological reality. But the delivery of the molecule is a different question from the chemistry of the molecule, and here the picture is more nuanced. Extended release formulations, versions of a drug that release the active ingredient more slowly, producing more gradual changes in blood level rather than the peaks and troughs of immediate release dosing, tend to have lower dependence profiles for many CNS drugs, because the brain's adaptation to a drug is partly driven by the rate of change in drug concentration, rather than the concentration itself. Pfizer did eventually develop an extended-release version called Lyrica CR, approved in the United States in 2018. Whether this formulation meaningfully reduces dependence risk in real-world clinical populations over extended periods of use is still being studied. The fact that it arrived in 2018, 14 years after the original approval, is a timeline that speaks for itself. Dosing guidance could have been more conservative from the beginning. Post-marketing data suggests that dependence and withdrawal severity are dose-related, that patients on higher doses and those who escalated quickly were more likely to experience significant problems on discontinuation. The doses approved by the FDA were based on efficacy data from clinical trials of specific duration. They were not informed by long-term safety data on discontinuation, because that data did not exist at the time of approval. Starting doses could have been lower, escalation could have been slower, maximum doses could have been set with more caution. None of these are radical interventions. They are the kind of adjustments that tend to happen after the population-level evidence accumulates, which is to say, after the harm has already occurred. The specific molecule will change. The drug at the center of the next version of this story will have a different name, a different mechanism, a different approved indication, and a different set of television advertisements featuring different soft focus imagery. The story itself, the structural story, the story of a drug with genuine utility marketed beyond its evidence base to a population given insufficient information about long-term use, will not change because the forces that produce it have not changed. In the current pharmaceutical landscape, there are several drug classes that a thoughtful person, applying the pattern recognition that the Lyrica story teaches, might look at with particular attention. The GLP-1 receptor agonists, drugs like semaglutide, sold under names like Ozempic and Wegovy, are being prescribed across an enormous and rapidly growing population for a range of weight-related conditions. The clinical trial evidence for their efficacy in specific populations is robust. The enthusiasm surrounding them, in both clinical and consumer culture, is extraordinary. And the long-term effects of extended use across the diversity of the real-world population, the withdrawal properties, what happens physiologically when someone stops these medications after months or years of use, these questions are actively being studied but are not yet fully answered. This does not mean that GLP-1 agonists are the next Lyrica. They may not be. The pharmacological profile is different, the regulatory environment is different, and the clinical community is, in some respects, more alert to the pattern than it was when Lyrica was introduced. But the structural conditions that made Lyrica's story possible, enormous commercial incentive, broad patient population, genuine efficacy in appropriate cases, real uncertainty about long-term effects, pressure on prescribers from patient demand shaped partly by advertising, are present. And the questions that should be asked early, the questions that were not asked early enough about pregabalin, are the same questions. Who is this drug appropriate for and who is it not appropriate for? What does long-term use do to the body? What happens when you stop? What does the patient need to know before they say yes to the first prescription? These are not hostile questions. They are not anti-medicine questions. They are the questions that informed consent requires and that good medicine depends on. They are also the questions that the commercial machinery surrounding a successful drug has historically been poorly motivated to answer, with the same energy and investment that it brings to the question of why you should start taking it, asking them loudly, early and persistently, before the coroner's data accumulates, before the patient forums document the withdrawal experience in detail, before the settlement checks are written, is the specific work that the Lyrica story argues for. The Lyrica story is not over. The patents have expired. The settlements have been paid. the regulatory guidance has been updated, the prescribing rates in some markets have declined, and the most aggressive phase of commercial promotion has ended. If you are looking at a checklist of things that are supposed to happen after a drug causes significant harm, most of the boxes have been checked. And yet the full reckoning, the systemic, structural, honest accounting for how the conditions that produced this story came to exist and why they continue to exist, has not happened. The boxes are checked. The system is largely unchanged. The pharmaceutical industry is not going to dismantle the marketing infrastructure that shaped Lyrica's history, because that infrastructure is not a mistake that was corrected. It is a feature that is working as designed, generating revenue in the present, with consequences that are distributed across future years and future patients and future settlement negotiations. Direct-to-consumer advertising for medications with significant dependence profiles is not going to be banned in the United States because the investment in lobbying against such a ban is substantial. The political will to confront it is limited, and the framing of the practice as a matter of consumer information rather than commercial pressure has proven durable. The prescribing culture that normalized broad CNS drug use is not going to transform overnight because a post-marketing analysis found harm. Cultures change slowly through education and experience and the gradual replacement of practitioners trained under old paradigms with practitioners trained under new ones. What changes in the meantime is the accumulation of evidence, of clinical experience, of patient-generated knowledge, of regulatory guidance that reflects what the population data shows, of training programs that have incorporated the lessons of the previous generation's prescribing into what they teach the next. This accumulation is real, it is happening, and it matters, but it is slow. It is slower than the pace at which harm occurs, and that lag between the emergence of a problem in the real world and the institutional response that adequately addresses it is not a technical failure. It is a structural one, built into a system in which the incentives to identify and respond to harm are systematically weaker than the incentives to develop, approve, and promote treatment. The patients who struggled to taper off Lyrica and who documented that struggle in online communities helped build the knowledge base that now informs better discontinuation guidance. The families who lost someone to a pregabalin-involved overdose and who spoke to journalists and advocates and regulatory bodies helped build the case for reclassification. The physicians who pushed back against the prescribing culture, who wrote papers and gave presentations and advocated within their professional organizations for more cautious use, helped shift the guidelines. The journalists and researchers who examined the marketing practices and the clinical trial data and published what they found helped make the pattern visible to people who had not seen it. This is how the reckoning happens, not all at once, not cleanly, not in a way that feels proportionate to the harm, because nothing about the way institutional accountability works feels proportionate to the harm from inside the experience of the harm. It happens in the accumulation of individual acts of honesty and advocacy and careful attention carried out by people who are not required to do it and who did it anyway because they understood that the alternative was silence and that silence was what the problem needed to continue. The Coffin tablet earned its name. The people who gave it that name deserved better from the system that gave them the drug, and the history they are part of, this history, the one you have just spent time inside, deserves to be told clearly and completely, so that the next time a warm advertisement appears on a screen late at night, offering something that sounds like the life you used to have, more people are ready to ask the questions that should have been asked about Lyrica from the very beginning. There is a ghost that walks through every pharmaceutical scandal, and its name is thalidomide. You know the story, or at least the outline of it. because it is the story that medicine invokes whenever it wants to remind itself of what happens when a drug reaches the market before the full picture of its risks has been understood. The sedative prescribed to pregnant women in the late 1950s and early 1960s, the birth defects, the thousands of children born with limb abnormalities across Europe, Australia and Canada, the Francis Kelsey of the FDA who refused to approve it in the United States, a decision that saved an unknowable number of American families from the same outcome, the regulatory reforms that followed, the tightening of approval standards, the institutional memory of a catastrophe that was supposed to make the next one impossible. And yet here we are, decades later, telling another version of the same story. Not the same drug, not the same mechanism of harm, not the same scale of immediate physical devastation, but the same structural pattern, a drug with genuine utility, approved for specific populations, expanded beyond its evidence base by commercial pressure, with a risk profile that was understood incompletely at the time of broad rollout and paid for by patients who had not been given the information they needed to protect themselves. The question that thalidomide was supposed to answer permanently was, how do we make sure this does not happen again? The regulatory reforms that followed it, the requirement for more rigorous preclinical and clinical trial data before approval, the formalization of the drug approval process in the United States and other countries, the establishment of the institutional framework that governs pharmaceutical development were genuine improvements. They made a thalidomide-style disaster less likely. They did not make it impossible, and they did not address the post-approval phase of a drug's life, which is where the Lyrica story largely played out. The gap that thalidomide exposed was in the approval process. The gap that Lyrica exposed was in what happens after approval, in the years and decades of real-world use that follow the controlled conditions of clinical trials, in the population of patients who do not look like trial participants, in the conditions that are not the approved indications, in the durations of use that extend far beyond what any trial measured. Post-approval surveillance, post-approval education, post-approval accountability. These are the weaknesses that the thalidomide reforms did not address. Because they were not visible in the thalidomide story, they became visible in the stories that came after, Neurontin and Lyrica among them, and they have still not been adequately addressed. The ghost of thalidomide is invoked as a warning. The lesson it is supposed to teach is vigilance. The uncomfortable truth is that vigilance applied only to the approval process and not to the commercial life that follows approval is vigilance with a blind spot large enough for several more scandals to walk through. Lyrica walked through it. Something else is walking through it now. The ghost is still speaking. The question is whether anyone in a position to act is listening in the right direction. Not every physician who encountered Lyrica's aggressive promotion accepted it uncritically. There were doctors, a minority, but a real and consequential minority, who looked at the clinical trial data, looked at the marketing claims, looked at the patients coming back to their offices with side effects they had not been warned about, and said, out loud and in professional context, that something was wrong. Their stories are part of the Lyrica history, and they are worth telling, because they illuminate what the system does to people who try to correct it from inside. Some of these physicians were academics, researchers at medical schools and teaching hospitals, who had the institutional standing to publish critical analyses of the trial data, to write editorials questioning the evidence base for off-label prescribing, to present at conferences the findings that the pharmaceutical-funded continuing medical education was not presenting. Their work was real and it mattered. It contributed over years to the gradual updating of guidelines and the growing caution among prescribers who read the literature carefully. But it was slow, and it was contested, and the resources available to challenge a well-funded marketing campaign with an academic paper are not equivalent resources. Some were clinicians in practice who noticed the pattern in their patient population, the weight gain, the cognitive fog, the patients who tried to stop and could not, and began prescribing differently, tapering patients off who did not need to remain on the drug, declining to start new patients for indications where the evidence was thin. These physicians were not making dramatic public stands, they were making clinical judgments that differed from the prevailing culture of their specialty, and they were doing it without institutional support and sometimes in the face of patient resistance from people who had seen the advertisements and arrived at the appointment expecting a prescription. Some faced more direct consequences. Physicians who were identified as low prescribers by pharmaceutical sales representatives and sales forces absolutely tracked prescribing patterns at the individual physician level, received more attention, more visits, more invitations to speaker events, more of the relationship building that is the interpersonal face of pharmaceutical marketing. The pressure was rarely overt. It did not need to be. The structure of the relationship, the sales representative who knows your name, who remembers your preferences, who brings lunch for the office staff, who invites you to a dinner event where a colleague you respect will speak, creates a social and professional environment in which the path of least resistance is to prescribe as expected. Deviating from that expectation required a degree of deliberate resistance that most physicians in a busy practice were not positioned to sustain indefinitely. The physicians who pushed back did not stop the Lyrica story. The forces arrayed against them were too large and too well-resourced for a minority clinical voice to redirect, but they slowed it in specific places and specific practices, and they created the intellectual foundation that eventually supported the guideline revisions and the reclassification decisions that followed. They deserve to be named in the history, even without their names, as the people who saw the problem early, and said so at a cost that was real, if not always dramatic. There is a dimension of the Lyrica story that does not get discussed as often as the dependence and the overdose data, partly because it is subtler and partly because it sits at the intersection of medicine and something that most people do not think of as a medical phenomenon at all, the experience of sleep. But for a very large number of patients who were prescribed pregabalin, the relationship between the drug and their sleep was one of the most significant aspects of their experience, both while they were taking it and during the process of coming off it. And it tells you something important about what the drug is actually doing to the nervous system over time. Pregabalin, as a central nervous system depressant that reduces neuronal excitability, has sedating properties. For some patients, this is part of its therapeutic value. The pain that had been keeping them awake is reduced and the sedation helps them fall asleep in a way they had not been able to manage for months or years. For these patients, Lyrica was not just a pain medication. It was, in practice, a sleep medication, and the sleep it provided felt restorative in a way that years of pain-disrupted nights had made them desperate for. This is not a trivial benefit. Chronic sleep deprivation has its own devastating effects on physical and mental health, and a medication that restores sleep for someone who's been without it for a long time is doing something genuinely meaningful. But the nervous system's adaptation to pregabalin, the upregulation of calcium channels, the compensation that the brain makes for sustained suppression, extends to the mechanisms that regulate sleep. Over time, the brain comes to rely on the sedating effect of pregabalin as part of its sleep architecture. The natural mechanisms of sleep induction, which were already compromised by chronic pain, become further compromised by the brain's adjustment to external suppression. And when pregabalin is reduced or withdrawn, the result is often a period of insomnia so profound and so specific that patients consistently describe it as different in quality from ordinary sleeplessness, not merely difficulty falling asleep, but a complete inability to reach the restorative stages of sleep, a restlessness that persists through the night with a physiological urgency that no amount of sleep hygiene or relaxation technique adequately addresses. This withdrawal insomnia was one of the most commonly reported and most distressing aspects of the tapering experience documented in patient communities. It was also one of the most clinically underappreciated, because insomnia is such a common complaint in chronic pain populations that its emergence during a Lyrica taper was easily attributed to the return of the underlying condition rather than to the pharmacological process of withdrawal. The distinction mattered enormously to the people experiencing it and to their families watching them go through it, even when it didn't matter sufficiently to the clinical guidance available at the time. The sleep dimension of the Lyrica story is also, in a quiet way, a window into how the drug was being used beyond its approved indications. Many patients prescribed pregabalin for pain found that its most immediate and most welcome effect was on their sleep, and many patients prescribed it primarily because their physicians knew that their sleep was catastrophically disrupted by pain. The drug was doing something useful, but it was doing it by becoming structurally integrated into the brain's regulation of a fundamental biological process, and the implications of that integration had not been adequately communicated to anyone involved. There is a patient, not a specific person, but a composite of a pattern that appeared, with notable consistency, across the testimonies and forum posts and adverse event reports that accumulated in the years of Lyrica's commercial life, who represents perhaps the clearest failure point in the drug story. This patient did not have diabetic neuropathy. They did not have postherpetic neuralgia. They did not have a confirmed fibromyalgia diagnosis arrived at through careful clinical assessment. They had back pain. Non-specific, common, the kind of back pain that affects most adults at some point, and that in the vast majority of cases resolves with time and appropriate management without requiring a central nervous system drug. The kind of back pain that used to be treated with a few days of rest, some anti-inflammatory medication, and a referral to a physiotherapist. The kind of back pain that is, in the long catalogue of human physical complaints, about as ordinary as it gets. This patient went to their primary care physician with a back that had been hurting for 6 weeks. 6 weeks is long enough to be genuinely disruptive, long enough to affect sleep, to interfere with work, to make ordinary movements feel like negotiations, but not long enough by most clinical guidelines to indicate a serious underlying pathology. The physician, working within a system in which opioids were increasingly restricted, following years of devastating misuse and overdose, in which physiotherapy waiting lists stretched weeks or months into the future, in which the appointment slot was 12 minutes, and the patient sitting across the desk was in genuine discomfort and needed something, reached for pregabalin. It was on the formulary. It was inexpensive, particularly after the generic became available. The mechanism, calming overexcited nerves, reducing the amplified pain signals that a sensitized nervous system produces, sounded relevant to a pain complaint in the same loose, plausible way that a description of any CNS modulating drug sounds relevant to any pain complaint if the description is broad enough. The physician had been educated about its use in pain conditions through a continuing medical education event that had not made a strong or memorable distinction between the approved neuropathic indications, the specific well-characterized conditions for which the clinical trial data was robust, and the broader, vaguer category of pain in general. The prescription was written, the appointment ended, the patient left with something that felt like help. 6 months later, the back pain had resolved. As non-specific back pain usually does, given time and the body's remarkable capacity to heal itself from the ordinary insults of daily life. But the patient was still taking pregabalin, not because anyone had assessed whether continued use was appropriate, not because there had been a follow-up appointment specifically designed to ask that question, but because stopping had been attempted once, briefly and without guidance, and the attempt to produce symptoms, a return of pain, a sharpening of discomfort that felt like evidence that the drug was necessary, that the pain was still there underneath and the pregabalin had been holding it back. This interpretation was understandable. It was also wrong. What the patient had experienced was not a return of the original back pain. It was the early expression of withdrawal from a central nervous system drug that the nervous system had spent 6 months incorporating into its baseline. The difference between those two things is clinically significant and practically invisible to someone who has not been told to expect one and look for the other. 12 months after the original prescription, the patient was on a stable dose, sleeping through the night, because the drug's sedating effect had, over months, become integrated into the architecture of their sleep in a way they had not noticed happening and could not have described if asked. Having gained somewhere between 10 and 20 pounds, because weight gain is a common, dose-related and frequently underemphasized side effect of pregabalin that tends to accumulate quietly over months rather than arriving dramatically in a way that prompts a conversation. The patient was functioning. They were not in crisis, but they were functioning at a level of cognitive clarity that was somewhat below what they remembered from before starting the medication. A slight slowing, a mild fogginess, a sense of not quite being fully present in their own thinking that had arrived so gradually it had been easy to attribute to aging, to stress, to the general ambient fatigue of a busy life. It was not those things, it was the drug. But the drug had arrived at the same time as a period of genuine pain and genuine stress, and the cognitive changes it produced had been absorbed into the general texture of that period without being separately identified. 3 years after the first prescription, a new physician reviewed the medication list during a routine appointment and asked, with the fresh eyes of someone who had not been present for the original clinical decision, why this patient was still taking pregabalin. The patient could not fully answer the question. The original back pain was gone, had been gone for more than 2 years. The documentation in the clinical record of why the drug had been started was sparse. A note about back pain, a prescription, no stated indication, no discontinuation plan, no follow-up instruction. The clinical indication, such as it had ever been, no longer applied. But the drug had become, in the quiet and entirely unannounced way that these things happen in nervous systems that are adapting to their chemical environment without informing their owner, essential to the patient's daily functioning in a way that nobody had planned for, nobody had anticipated, and nobody had prepared them to manage. What followed was not dramatic. There was no hospitalization, no emergency intervention, no moment of acute crisis that crystallized the situation into something visible and actionable. There was a slow, careful, frequently uncomfortable tapering process that took the better part of a year, conducted partly with clinical guidance that was more uncertain than either the patient or the physician wanted to acknowledge, and partly with the help of an online community of strangers who had been through the same thing and had documented what they had learned in enough detail to be genuinely useful. There was a period of withdrawal insomnia so specific and so unrelenting that the patient would later describe it as unlike any sleeplessness they had experienced before or since. There was a period of anxiety that arrived at a severity that felt, from the inside, like the emergence of a new and serious mental health condition, and that was, in fact, the nervous system recalibrating itself to the absence of the suppression it had spent 3 years compensating for. There was eventually resolution, a gradual return to something that felt like the person they had been before the back pain, before the prescription, before the quiet 3-year rearrangement of their neurological baseline. But the journey from the prescription to that resolution took 4 years in total, and the original back pain had resolved on its own within 3 months of the first appointment. This patient is not a dramatic story. That is precisely why it matters. The dramatic outcomes, the overdoses, the deaths, the severe withdrawal crises that resulted in hospitalization, were real, and they mattered, and they are the outcomes that drove regulatory action and generated headlines and gave the Coffin tablet its name. But the undramatic story is where the numbers live. For every person whose Lyrica experience ended in a coroner's report, there were thousands whose experience ended in a quiet, prolonged, poorly supported struggle to stop taking a drug they never should have started, for a condition it was never proven to treat, prescribed in 12 minutes by a physician who was doing their best, inside a system that had given them inadequate tools and excellent marketing. Multiply that undramatic story across the scale of off-label prescribing that characterized Lyrica's commercial life, across the back pain prescriptions, the anxiety prescriptions, the sleep disorder prescriptions, the post-surgical pain prescriptions written without a discontinuation plan, and you have the actual size of the problem, not the dramatic edge of it, the whole of it. And the whole of it is considerably larger and considerably more ordinary than the headlines ever suggested. And so, here we are. At the end of a very long night, at the end of a very long story, somewhere between the 1970s laboratory, where a chemist was trying to calm an overexcited brain, and the online forum where a person at 2 a.m. was trying to figure out how to stop taking a pill that nobody had properly explained to them. That is a long distance to travel in one sitting, and if you have made it this far, if you're still here, pillow tucked just right, fan humming its soft white noise in the background, eyes growing heavier with each sentence, then you have done something that most people never do with the stories that shape their lives. You paid attention to the whole thing, not just the advertisement, not just the headline, the whole thing. And that matters more than you might think lying there in the dark. Because here is what the Lyrica story is really about, underneath all the pharmacology and the legal settlements and the regulatory classifications and the clinical trial data. It is about trust. The particular, vulnerable, necessary trust that exists between a person who is suffering and a system that is supposed to help them. The trust that you extend every time you sit in a waiting room, every time you describe your symptoms to someone with a prescription pad, every time you swallow a pill because a person you believe in told you it would help. That trust is not naive. It is rational. Medicine has done extraordinary things with it. The conditions that killed your great-grandparents are managed routinely now. The pain that once had no answer has answers now, imperfect answers, incomplete answers, but real ones. The trust is warranted in the broad direction. But trust, extended into a system with commercial incentives that do not always align with your well-being, requires something to protect it. It requires transparency. It requires the full conversation, not the abbreviated one. It requires a physician who's been educated by sources that are not primarily motivated by whether you fill the prescription. It requires an advertisement, if there must be advertisements, that treats you as someone capable of processing risk information at normal human speed, rather than someone to be managed past it. It requires a regulatory system that watches what happens after approval with the same rigor it applies before. It requires, at the most basic level, the belief that you deserve the whole picture, not because you are a sophisticated medical consumer who has done your research, but simply because you are a person, and the decision being made is about your body, and your body belongs to you. The people who took Lyrica and were helped by it, who slept through the night for the first time in years, who walked to the kitchen without dread, who returned to work, who found their lives again on the other side of pain that had been unmanageable, those people are part of this story too. Their relief was real. The drug did something real for them. And the researchers who developed it, the physicians who prescribed it carefully and with genuine attention, the regulators who approved it based on the data available to them, they were not villains. They were people operating within a system, making decisions within the information and the incentives that system provided. The villainy in this story, to the extent there is villainy, is structural. It lives in the gap between what the system was designed to optimize for and what the people inside it actually needed. The people who were harmed, who were prescribed a drug for a condition it could not treat, who developed a dependence nobody warned them about, who spent months in a withdrawal that nobody prepared them for, whose families received the worst phone call, those people are also part of this story. They did not fail the system. The system failed them. And the distance between those two statements is where accountability lives, and where the work of making things better has to begin, if it begins at all. You're lying in your bed right now, in a world that has central heating and indoor plumbing and running water and medications that have, on balance, extended human life and reduced human suffering in ways that would have been unimaginable to the people who came before you. That is extraordinary. That is genuinely worth a moment of quiet gratitude in the dark. And at the same time, the world you're lying in has pharmaceutical companies whose primary obligation is to their shareholders, regulatory agencies that are under-resourced and slower than the problems they're chasing, physicians who are working in 12-minute increments with inadequate training on the drugs they're prescribing, and patients who are being asked to make consequential decisions with incomplete information. Both of those things are true at once. The extraordinary and the inadequate sitting right next to each other, which is where most of the important things in life tend to sit. So take that with you. Not as anxiety. You have done enough tonight, and your nervous system deserves the rest it came here for, but as the quiet, specific awareness that the person best positioned to protect you inside any medical encounter is you, the person who asks the questions, the person who says, before you write that prescription, can you tell me how long I will be on this, and what stopping looks like, and what the evidence is for my specific condition. The person who knows, because they spent a night listening to this story, that the advertisement and the reality are not always the same thing, and that the gap between them is worth examining before you step into it. The people who took Lyrica, all of them, the helped and the harmed and everyone in between, were just people. Ordinary people in pain looking for relief, which is perhaps the most human thing there is. They deserved better information. They deserved more time. They deserved the conversation that should have happened in the room. And in telling their story, this long, complicated, uncomfortable, genuinely important story, we honour what they went through, we learn what they paid to teach us, and we try, in whatever small way a story can try, to make the next person's yes a more informed one. Sleep well. You have earned it. And tomorrow, if you or someone you love is sitting across from a prescription pad, remember what you heard tonight. Ask the questions, all of them. You deserve the answers.